Hi, everyone. Welcome to the Lacked Fact Weekly Podcast, which highlights recent clinically relevant research, policy statements, and protocols that you, as a practicing lactation professional, would probably like to know about. I'm your host, Dr. Eglash. I'm a board-certified family physician and breastfeeding and lactation medicine specialist at the University of Wisconsin School of Medicine and Public Health. This podcast is written and produced by the nonprofit organization IABLE, which is the Institute for the Advancement of Breastfeeding and Lactation Education. We have no commercial funders for this podcast series. Today's Lacked Fact comes from the following article, Cannabis Use During Pregnancy and Lactation, which is an American College of OBGYN clinical consensus report that was published in OBGYN or Obstetrics and Gynecology Journal in October 2025, volume 146, issue number 4. And this is essentially an update from their 2017 opinion statement. This is my third Lacked Fact podcast in the last year on cannabis or THC. And I'll admit that I'm somewhat fascinated with THC because I grew up with it in the 60s and 70s when it was much more popular than alcohol among young people. So it was really part of my growing up. Cannabis use has never gone away, although there is a documented resurgence of cannabis use over time. So it's having its moment or moments. According to the ACOG consensus, about 23% or nearly 1/4 of pregnant individuals in high-income countries are documented to be using cannabis. Although there's increased availability and familiarity with cannabis and increased social acceptability, there's also been a perception that cannabis is safe to use during pregnancy, particularly in the first trimester when the use tends to be the greatest for nausea and vomiting. Then it appears that cannabis use tends to taper off during gestation, and then it picks up again about 6 to 12 months postpartum. I didn't realize the wide variety of methods by which cannabis is consumed. So in addition to smoking, vaping, and eating products with cannabis is available in other vehicles, such as transdermal substances, such as patches and gels. It's also available as chewing gum, vaginal suppositories, and even tampons. In addition, there are some items that can be inserted rectally that are embedded with THC. The significance of this is that if a patient is asked if they're smoking cannabis or eating products with THC, they may say no, but that would be correct if they are using it in another way, so we might miss their use. This consensus statement was developed by first performing a literature review, followed by the development of a number of proposed recommendations, and then the members of the Committee on Clinical Consensus voted on the proposals, and each recommendation had to reach a 75% consensus. So I'm going to run through the major recommendations. First, the first recommendation, this is actually one of the last points in the consensus statement, which is that cannabis use disorder is considered a diagnosis in the DSM-5 manual. The DSM-5 manual is the Diagnostic and Statistical Manual of Mental Disorders, which is largely used by psychiatrists. And cannabis use disorder is defined as using cannabis in a problem-causing pattern, which means, for example, taking larger amounts or for longer periods of time than intended, and or having symptoms of craving, and or continuing cannabis use even when experiencing physical, social, or interpersonal problems caused by cannabis. There are no U.S. Food and Drug Administration approved medications for the treatment of cannabis use disorder. And adverse symptoms associated with cannabis use tends to be dose-related, so strategies that help to reduce the amount of use can actually provide some benefit. The second recommendation that I want to discuss is that obstetrician gynecologists and other OB providers should be knowledgeable and educate all individuals, whether they are seen pre-pregnancy, during pregnancy, or postpartum. They also state that there's no medical indication for the use of cannabis during pregnancy or postpartum, and they recommend having this conversation with everyone, not just those who disclose use. Otherwise, people are just basically not going to disclose that they do use. The consensus group acknowledges that there are several reasons why people do use cannabis during pregnancy, including treating pre-existing conditions or using it as a replacement for other more harmful substances like meth, for example. Cannabis has been used for anxiety, depression, insomnia, chronic pain, nausea. So a conversation about cannabis use should also include a discussion about the symptoms that they're using it for and medical options to treat those symptoms. A third recommendation is that physicians and other providers should perform universal screening by interviewing, self-report, or a validated screening tool for cannabis use during pregnancy or postpartum. They have a nice table in the statement that lists a variety of screening assessment tools and details about these tools, such as what substances they screen for, which populations they're appropriate for, and who can administer the screening. Biologic testing, such as urine drug screening, is not considered to be screening. I should say urine drug testing, not screening. So these should not be used as screening assessments for cannabis use because, first of all, THC, which is the major psychoactive compound, is fat soluble, so it can last for a long time in body tissues. And having a positive test does not diagnose substance use disorder, since a positive test result does not correlate with the severity of use. Also, biologic testing, such as hair or urine, can have significant social and legal consequences, so should always be done with the patient's informed consent. Because guidelines and reporting drug test results have been found to be biased against racial and ethnic minority groups, patients who are Black are 4 to 10 times more likely to have their drug screen be reported to Child Protective Services as compared to patients who are white. Fourth point is that obstetrical healthcare providers should advise cessation of cannabis use during pregnancy and lactation. However, continued cannabis use is not considered a contraindication to breastfeeding, and breastfeeding should not be discouraged. So this recommendation is unchanged from the 2017 statement. We now know that cannabinoid receptors are present in the fetus as early as 5 weeks, and that THC, being fat soluble, can cross the placenta and transfer into breast milk. The amount of THC that reaches the infant is going to depend on the dose and the frequency of use, and fetal concentration of THC has been reported to be about 10% of the maternal concentration, and the risk of adverse effects will increase in a dose-dependent fashion. So again, encouraging people to decrease the amount of use can help to mitigate negative infant effects. In terms of like what we know about the effect of cannabis on the fetus, there is an association with cannabis use during pregnancy with low birth weight, small for gestational age status, admission to the NICU, and perinatal mortality. There's been concern for neurocognitive and behavioral dysfunction, including attention deficit disorder, behavioral and short-term memory challenges, as well as intellectual disabilities. It's been difficult to sort out to what extent these outcomes are related to gestational exposure versus lactation. For the parent, cannabis hyperemesis syndrome has been recognized as a complication of moderate use of cannabis, which is characterized by cycles of nausea, vomiting, and abdominal pain. And people will report that this nausea and vomiting is alleviated by a hot shower. Cessation of cannabis can totally alleviate those symptoms. It's important to identify this syndrome and distinguish it from nausea associated with pregnancy. And for people who want to achieve complete resolution of cannabis use, there's not really any kind of standard treatment. But people who have cyclical vomiting are oftentimes motivated to stop cannabis. And the statement recommends supportive measures such as dopamine antagonists, topical capsaicin cream, and IV fluids. People who are using cannabis for pain or for anxiety and stress should be evaluated for their symptoms, and those symptoms should be treated with standard evidence-based approaches. The fifth recommendation I'm sharing with you is that the report discusses that cannabis withdrawal syndrome is considered a recognized disorder. So we talked about cannabis use disorder, but there is a recognized cannabis withdrawal syndrome. And I want to point this out because many people think, oh, cannabis is not addictive, like you should be fine just to stop it. But it really is a problem, which makes it difficult for people to stop it. So this is characterized by behavioral, emotional, and physical symptoms, including irritability, anxiety, decreased appetite, abdominal pain, tremors, and headache. And this can occur within 24 to 72 hours after the last cannabis use and can continue for 2 weeks. The severity of these symptoms correlates with the amount of cannabis consumed, especially if they are using it more than 2 to 3 times a day. And then withdrawal symptoms can be a barrier to achieving cessation. So recognizing these symptoms and helping people with management to alleviate their symptoms is important. And then the last thing I want to share about this statement is that the committee recommends using motivational interviewing to assist individuals in making behavioral changes using patient-centered approaches, along with identifying and promoting protective behaviors and reducing risk factors. So, for example, helping with peer, family, and community social support can be effective in reducing cannabis use, whereas if the partner or other family members are using substances, that can be associated with greater cannabis use. The committee also suggests some evidence-based risk reduction strategies to educate and reduce the risk of cannabis use. So things like cognitive behavioral therapy, brief electronic or text messaging interventions during pregnancy to educate patients, and paraprofessional home visiting interventions, as well as structured exercise programs have been found to help improve the quality of life, which helps to reduce cannabis use. I hope this was helpful. Hey everyone, thanks for listening. I encourage you to check out IABLE at lacted.org, which is LACTED.org, to learn more about our educational projects, courses, educational handouts, videos, live conferences, and webinars. By becoming a member, you are not only supporting our free projects, but you will also receive a series of benefits, which you can learn about at our website. I'll be back with another LACT fact in a few weeks.